Well, hello, everybody, and welcome to the second centennial lecture for the Social Science Research Council. I'm Anna Harvey. I'm the president of the SSRC, and I'm so pleased to welcome you all here today. Through the centennial lectures, we are celebrating the founding of the Social Science Research Council 100 years ago, as well as the achievements of the social and behavioral sciences over the last 100 years. We're partnering with the institutions in our college and university fund for the social sciences, which is a network of 46 colleges and universities that works with the council to support policy relevant social and behavioral science. And we've invited faculty from this network to talk about the frontier of research on 10 important policy issues that represent the last 100 years of the council's work. Last month, we focused on immigration, the subject of the council's very first research initiative in the 1920s. This month, we're focusing on social insurance, which was a critically important research area for the council in the 1930s. On April 27th, 1933, the Rockefeller Foundation approached the Social Science Research Council asking for, and I quote, "Within 48 hours, suggestions for immediate research relating to urgent problems confronting the federal administration in the current national emergency." And that request launched the council's work on Social Security in the 1930s. The council established a committee on Social Security whose mission was to advise the Roosevelt administration on the economic effects of different forms of social insurance. And for the next 7 years, the Committee on Social Security maintained a research presence in Washington and served as a forum for bringing social and behavioral science to bear on the creation of a national system of Social Security. We now know that that system has been enormously effective. Social Security reduces the elderly poverty rate by about 75%, which is in effect 62 times as large as the second most important program for the elderly, SSI. In the decades since the establishment of Social Security, the new frontier in social insurance provision has been the provision of health insurance. And we have been gradually, some would say too gradually, expanding health insurance coverage, primarily through the Medicaid program. And researchers have been finding dramatic effects from this expansion of health insurance coverage. We're very fortunate to have with us today one of the country's leading researchers on the effects of health insurance expansion, Laura Wherry from New York University. Some of you may have seen the New York Times story a couple weeks ago featuring Laura's work with co-authors on racial and income disparities in maternal and infant mortality in the United States, showing both that even the wealthiest mothers in California have mortality rates that are higher than in Sweden, where public health insurance coverage is much more extensive, and that within California, the wealthiest Black mothers have mortality rates that are no lower than the poorest white mothers. So Laura is doing really amazing work. She's going to share with us today her path-breaking research on health insurance. I'm so happy to welcome her. Feel free to post questions in the Q&A as Laura is talking, and I'll field them to her after she winds up. We'll have about 15 minutes of time for Q&A after Laura is done. So Laura, it's so good to have you here today. Thanks for being with us today, and the floor is yours.
Hi, thank you so much for having me here today. It's an honor to be a part of the Centennial Lecture Series for the Social Science Research Council. And as Anna so generously introduced this research and this talk, today I'm going to be talking about an important social insurance program in the US that was actually created in the 1960s under the Social Security amendments. And this is the Medicaid program. And today's talk is structured to just provide a brief introduction to the Medicaid program, and then walk you through a series of findings from papers by myself and collaborators where we've tried to provide new evidence on the causal effects of Medicaid on the health of different population groups in the US. So the US, similar to many other high-income countries, provides different types of social insurance programs. These are government interventions that provide insurance against unexpected and negative events that can occur to individuals. This includes a broad range of risks, and one of those is poor health or negative health events. Medicaid is one of the nation's primary social insurance programs to protect against this risk. As I mentioned earlier, the program was introduced in the 1960s, specifically 1965 as part of the Social Security Act amendments. It was launched at the same time as the Medicare program. You can see here on this slide, this made the front page news, although most of the attention at the time was on the creation of the Medicare program, and there was less attention paid to its sister program, which was Medicaid. Medicaid is our nation's primary health insurance program for low-income individuals in the country. It is targeted to only certain low-income individuals, so it's not enough to have a low income to qualify for the program, but you also need to meet other eligibility criteria. When the program was first introduced, it was targeted to those groups that were considered to have the most need at the time, and these were groups that were already receiving cash assistance. This was primarily very low-income single mother families who received cash welfare, as well as low-income elderly individuals and individuals with disabilities who qualified for cash assistance under the Supplemental Security Income Program. The Medicaid program operates similar to any other health insurance program. Its beneficiaries receive access to free medical care, and that includes ambulatory care, care in the hospital, as well as long-term services. The program has drastically changed over the almost 60 years that it's been in existence, and it's really grown in size. Right now, enrollment is at its highest levels, and that's partly due to the public health emergency that we had during the pandemic, which required states to keep individuals enrolled on the program. Currently, it's estimated that there were over 86 million enrollees in the program in 2021. Just to give you some context, that's more than 1 in 4 Americans. And the expense was about $748 billion. And combined with its sort of offshoot program, which is the Children's Health Insurance Program, Medicaid expenditures represent about 3% of national GDP. So because Medicaid is a health insurance program, it can be argued that the primary goal of the program is to protect individuals against costly medical expenses that they may not be able to be prepared for and may be unable to afford. And there's been a lot of really important recent work that has shown that Medicaid is functioning well in this regard. Individuals who gain Medicaid also experience reduced financial hardship. They're less likely to pay out of pocket for medical care, less likely to experience catastrophic medical expenditures, and they have in general have better financial well-being. But Medicaid also has an important second role, which is providing access to healthcare to poor individuals. This includes individuals who are already sick or have high healthcare needs. This allows them to gain access to the healthcare that they need free of charge. It also provides access to regular and routine medical care for other individuals who are poor, including preventive services that may protect against future health risks. There has been a lot of study looking at the effects of the Medicaid program on healthcare utilization. And as you would expect, when you give people access, free access to healthcare, they use more of it. So there's a well-documented increased use of medical care under the Medicaid program. Now, one cost to be conscious of when you give people access to free medical care is sometimes they may use medical care even when the benefit to their health is low. Because their out-of-pocket cost is negligible or they don't pay anything for their health care, they're likely to use services that they may not otherwise use if they had to pay for them out of pocket. And this concept is sometimes referred to as moral hazard, and it contributes to the overall expense of the program. Because we know that Medicaid causes people to use more healthcare, that leads to a natural next question, which is, does their health improve? Presumably, some of this medical care is beneficial to their health, either in the short or longer term. And that's the focus of this talk today, is trying to answer this question of whether Medicaid improves health and to what extent. This is an important question to answer. We know that the US has a high degree of income inequality in health. As Anna mentioned, recently myself and collaborators documented some of these disparities in health, both by income and by racial status in the state of California. But we know in general that there's a high correlation between income and health in the US, and more so than other high income countries. So Medicaid in this respect could be an important policy tool for trying to reduce these disparities. It's also important because one of the stated policy goals of Medicaid is to improve health of the population. This is particularly true in the case of large expansions in the program over time to pregnant women and children. A lot of the motivation for those expansions in the program were poor US performance on infant health measures and child health. And the expansion of Medicaid has been sort of a primary policy tool to address that by expanding access to affordable health care. It turns out that whether or not Medicaid affects people's health is a pretty difficult question to answer. So unlike, excuse me, my lights are about to turn off. Okay. Okay. So we're unable to compare the health of people who are covered by Medicaid to those who are not. That's because people who are enrolled in Medicaid are often very different from individuals who are not. As I mentioned, you need to have a low income. Historically, to be eligible for Medicaid, you had to be one of the most disadvantaged population groups in our country. And so the characteristics of these individuals differ in major ways from people who are not enrolled in Medicaid. And this isn't limited to income, but includes income, as well as other types of exposures that could affect individuals' health. So if you just compare people enrolled in Medicaid to people who are not, you're likely to conclude that Medicaid is actually causing poor health outcomes because health status tends to be lower for the Medicaid eligible group. And there's a really nice paper by Seth Friedman, Andrew Goodman-Bacon, and Hammerlund that presents the case for this. So ideally, what we would do is randomly assign people to Medicaid coverage or not, but the opportunities for this type of experimental evidence of the effectiveness of Medicaid are rare. There is one very important study that did do this, which is the Oregon Health Insurance Experiment, and we learned a lot from this study, which randomized access to Medicaid in the state of Oregon for low-income adults. We learned a lot about healthcare utilization and financial well-being for those people who gained Medicaid. Unfortunately, some of the evidence for health effects was less clear. The study was underpowered to look at some rarer outcomes, such as mortality, which we're able to look at using other types of research methods. So the first challenge is you need to have a credible research design that allows you to construct a comparison group to tell you what health would look like for people who are eligible for Medicaid if they did not have access to Medicaid. And I'll be talking about how we do that in the context of our studies. The second challenge is related to data limitations and being able to measure changes in health. So survey data is a great source of data that gives you information on people's individual characteristics, so you know whether they are eligible for the Medicaid program. And it also provides health information that is typically self-reported. Unfortunately, it sometimes is unclear how to interpret changes in self-reported health when people gain access to Medicaid. Individuals, for instance, could report that they are better off, but that may be due to some of the increases in financial well-being that I mentioned earlier, or just having less stress now that they have insurance coverage. It may not actually reflect changes in physical health. Another potential concern is that when people gain access to Medicaid, they're now interacting with the healthcare system more than they otherwise would. They may find out about chronic health conditions or other conditions that they weren't aware that they had and could initiate treatment. And these types of interactions could actually could lead people to perceive that their health is worse after they gain Medicaid as compared to before. So ideally, we could demonstrate whether there are changes in health or not using more objective measures of health, such as clinical measures of health. Unfortunately, the data are often not available that allow us to do this. And sometimes when they are, such as when we look at changes in mortality, which is a very clear measure of health, we know that deaths are bad. It's also a very extreme measure of health, and so it's less frequent. And in this case, it can lead us to be underpowered to detect effects, especially if we're looking at effects at the population level when we know only some subgroup of that population actually gained Medicaid exposure. And then a final sort of challenge with looking at the health effects of Medicaid that I'd like to mention is that sometimes it can take time for these health effects to materialize. As I mentioned earlier, people gain access to regular and routine care, which includes access to preventive care. And that type of care is meant to protect people who are healthy now from future health risks. And it may be some time before we see the payoff from those types of investments in their health. So if we focus only on short-term evaluations of people gaining access to Medicaid, we may miss these longer-term health benefits. So that's where we aim to step in with the studies that I'm going to show you today. We want to provide new evidence on the health impacts of Medicaid using new research approaches or new data. And what we're doing, these are all analyses that rely on secondary data or data that already exists. So it's not experimental evidence, and we're not collecting the data firsthand. Instead, we're relying on quasi-experimental designs that take advantage of policy variation that was created by very large policy changes within the Medicaid program. These are expansions in eligibility to new population groups. And because we think that these changes in exposure to Medicaid are unrelated to people's individual characteristics, we're able to causally identify the effect of Medicaid on health. The second thing that we do in these studies is whenever possible, we rely on objective measures of health from administrative data. So the types of data sources that we rely on include natality records that have information on infant health outcomes, mortality data, as well as administrative hospital and emergency department data. So this allows us to look at some measures of health that are not self-reported. Whenever possible, we try to take a longer-term view to measure whether there are effects on health. And then finally, in the last study that I'm going to talk about today, we take advantage of some new data linkages to try to zoom in on the people who we think were likely most affected by the Medicaid expansions that we study. And that allows us to improve our detection of whether or not there are health effects. Okay, so the studies that I'm going to discuss are primarily focused on three very historic expansions in the program. The first is we're going to be talking about expansions for pregnant women and children. And then I'll talk about expansions for adults, which occurred much more recently under the Affordable Care Act. But this graph here shows you the millions of Americans who are enrolled in the program over time from the beginning in the 1960s to today. And you can see, as I mentioned earlier, that there's been a lot of growth under the program over time. I'm going to start by talking about Medicaid expansions for pregnant women. So this was one of the first sort of large expansions in the Medicaid program. In the 1980s and 1990s, there was a lot of momentum to improve infant health in the US. There was a very influential Institute of Medicine report that came out showing how poorly the US was faring on infant health and how many women were not getting access to adequate prenatal care. So this led Congress to take steps to expand the program to poor pregnant women, not just those who qualified for cash assistance. So before this change, it was still the case in order to be eligible for Medicaid, a woman would have needed to qualify for cash assistance, so be in a single mother family with a very low income. This change relaxes that criteria and expands to all women with incomes below the poverty line. This graph shows you these changes in Medicaid eligibility for prenatal care. This shows the fraction of women in the US of reproductive age who we estimate would be eligible for Medicaid in the event of a pregnancy. And you can see that this changes from about 13% of women being eligible in 1979 and climbs up to 44% by 1993. There was a very important study conducted in 1996 by Janet Curry and John Gruber, which looked at the short-term effects of these expansions and documented a large decline in infant mortality, as well as evidence of a decrease in the incidence of low birth weight among the more disadvantaged families. So this led my collaborator, Sarah Miller, and I to ask the question of whether this early health intervention had longer lasting benefits. And we were motivated by the fetal origins literature, which shows how early life health is really important for later life outcomes as an adult, both health and economic outcomes. So in this study, we build on the original Curry and Gruber study and use a similar research approach, which takes advantage of this variation across states in both the magnitude and timing of these Medicaid expansions for pregnant women. So you can see here in this map, this shows the change, our estimated change in eligibility for women of reproductive age from the beginning to the end of the period that I just showed you. And some states saw very large changes in eligibility, with about 50% of women gaining eligibility for Medicaid prenatal care, and other states saw much smaller changes. This was a function of other policies that were in place, as well as the characteristics of the population there. So we take advantage of this policy variation, and we link this onto a data set, which gives us information on the adult outcomes of individuals that were born during this period from 1979 to 1993. We use information on their state and year of birth to bring in information about the generosity of Medicaid prenatal care in their state when they were in utero. And then we look at the relationship between adult health and human capital outcomes for these cohorts to the generosity of Medicaid in their state. And we control for other state characteristics, other policies that they were exposed to over their life course, and other types of factors that could influence these outcomes, because we are trying to isolate the effects of the early Medicaid exposure. What we find in this study is lower rates of chronic illness as an adult and fewer hospitalizations. And we find this reduction in hospitalizations is those primarily related to chronic health conditions. We also find evidence of higher high school graduation rates for those cohorts who benefited from the expansions in Medicaid eligibility while they were in utero. In certain specifications, we find evidence of effects on earnings, as well as use of public assistance in adulthood for the more disadvantaged families. So we do some calculations in the paper where we estimate that the reduction in hospitalization costs in adulthood, and we're concentrated on ages 19 to 36, because that was sort of the oldest age of these cohorts at the time of our study. And we find this reduction in hospitalization costs offset about a quarter of the cost of the original Medicaid prenatal coverage. Some later work by economists Hendren and Sprung-Kaiser use estimates from our paper as well as the original Curry and Gruber paper to estimate that recipients of this Medicaid coverage were willing to pay almost 14 times the original cost to the government due to the value that they received through these benefits. So what we learned from this study is that benefits to prenatal Medicaid eligibility are still materializing years after implementation. As I said, we were only able to follow these cohorts through age 36. So there may be even larger effects in the longer term as these cohorts reach middle adulthood and they start to see larger increases in their income and maybe the emergence of chronic health conditions or other health conditions as they age. So we'll need to see more work to trace those out. But given the evidence that we have to date, this led to our next question was, given that we see these long-term benefits for these cohorts who received in utero Medicaid, and that they're now adults themselves having their own kids, will these effects persist to the next generation? And so for this study, Sarah and I teamed up with Marianne Page and Chloe East to look at whether there were effects on the next generation. So here, as I just kind of to walk you through this, because I know it can get a bit complicated, but the original Curry and Gruber study was looking at effects on infant health of in utero Medicaid coverage. The paper I just walked you through looks at the effects on the adult outcomes when those cohorts are now of adult age. And this next paper looks at the health of their infants now that they themselves are having kids. So we call these second generation effects of the program. And to look at this, we're using infant health data from birth records that we've merged on information on the mother's in utero exposure to Medicaid using her state and year of birth. So for this study, we updated our research design, and we took the map I just showed you of the variation in Medicaid exposure across states, and we put the states into two different buckets. So we have treatment states that saw large increases in Medicaid eligibility across the cohorts that we looked at, and we compared them to control states that saw much smaller changes in Medicaid eligibility. Using this classification of the states, we run an event study design where we're looking at the relative outcomes for the two groups of states and how they change over time relative to that year right before the Medicaid expansions. So here, this plot shows you eligibility for the in utero period for mothers born in the two groups of states. You can see it's very similar prior to the Medicaid expansions, and then we see an increase in Medicaid eligibility in utero in the treated states as compared to the control states after the expansions. So we take that research design and apply it to the second generation. And what we find is evidence that the birth weights of infants to the mothers who benefited from Medicaid eligibility while they themselves were in utero increases. So we find an increase in average birth weight for those mothers who gained Medicaid under the expansions. We also find evidence of a decrease in low birth weight for the second generation, as well as a decrease in very low birth weight. And we also see some evidence of a decrease in very preterm births and the incidence of small for gestational age. This is when infants are, their birth weight is less than the 10th percentile conditional on their gestation age. So what we learned from this study is that the health benefits of Medicaid persist beyond that first generation, that exposed generation. And this indicates that Medicaid's benefits are even higher than were previously documented when we just focused on the effects on the first generation. In the paper, we do some calculations to show that these changes in health are economically meaningful. We estimate that more than 60% of the initial cost of expanded prenatal coverage for the mothers was paid for by reductions in medical costs for lower birth weights for their second generation children. And this ignores any additional savings that may happen over the course of that second generation's life as they continue to age past the infant period. We also talk about how it's reasonable to expect that these benefits may continue to be passed on to future generations. And we do some calculations in the paper that tell us that if we count for intergenerational transmission of the magnitude that we see in our estimates, that implies that a cost-benefit calculation would be indicate benefits of about 30% larger if you take into account these additional generational benefits beyond the first generation. Okay, and I'm going to talk about Medicaid expansions for children. So I just talked about expansions for pregnant women, but Congress also took steps in the 80s to expand Medicaid eligibility to poor children. Because these were federally mandated changes, they were specified to apply to children born after September 30th, 1983, in an effort to phase in these changes for states. What this meant is that children born before and after this date experience very different childhood exposure to Medicaid. So this is a really nice source of policy variation that we believe is unrelated to underlying health that allows us to estimate the causal effect of this policy. So we use a regression discontinuity design that compares outcomes for kids born right before and after this date in order to estimate the effect of Medicaid exposure. And we look at effects on mortality, hospitalizations, and ED visits later in life. Now, this change in exposure primarily occurred at ages 8 to 14. These cohorts around this birth date cutoff were about age 8 when the policies went into effect. And when they were age 15, the state children's health insurance program was introduced, which covered children regardless of their birth date. So sort of wipes out that policy variation. So first, I'm just going to show you some evidence that these policies did affect Medicaid coverage at ages 8 to 14. Now, in our papers, and this paper is with Sarah Miller, Bob Kessner, and Bruce Meyer, we look at separately, we stratify children by race. We look separately at Black children and non-Black children. We do that because the later data sets that have health outcomes that we use do not have any information on family income. And we show in our papers that Black children were much more likely to gain Medicaid eligibility under this poverty change due to their low family incomes compared to other racial groups. And so what you see here is some evidence of a sizable increase in Medicaid coverage at ages 8 to 14 for Black children. So this is a regression discontinuity graph. It plots Medicaid coverage at ages 8 to 14 for each birth month cohort leading up to that birth date cutoff where you would gain Medicaid eligibility. And then it plots Medicaid coverage for the cohorts who follow that cutoff. So you see a jump, an increase in Medicaid coverage of about 16 to 25% compared to baseline coverage for Black children. We do not see a similar change in our paper for non-Black children. So I'm going to show you outcomes, health outcomes for Black children born on either side of this cutoff. So first we look at mortality rates for the cohorts born before and after this date at ages 4 to 7. So these are the ages before they gained Medicaid coverage. And as you would expect, we don't see a difference in mortality rates across this cutoff. So this supports our underlying assumption, which is that health is similar for kids born before and after this date. At ages 8 to 14, the period where they do gain Medicaid coverage, we see some evidence of a decrease in mortality. This is specifically mortality related to disease, so where the primary cause of death is disease related. And then at ages 15 to 18, we see pretty strong evidence of a decrease in mortality rates. We estimate this is about a 19% decrease in disease-related deaths at these ages for cohorts born after the cutoff who benefited from the Medicaid policy change. Next, we look at inpatient hospitalizations. We look at age 15, which is the first age right after they gained Medicaid eligibility. We don't really see evidence of differences in hospitalization rates around the cutoff, but we do see evidence of a decrease in hospitalizations at age 25, 10 years later. And this reduction represents about a 7 to 15 point reduction in hospitalization rates for cohorts who gained Medicaid coverage. And in the paper, we show that this is primarily due to a decrease in hospitalizations related to chronic health conditions. So this paper, I think, shows strong evidence of health effects of child Medicaid coverage, but it also shows that they took time to materialize. We didn't see these immediately during the period of coverage or just following it, but later in life. I will also say these improvements in the health of Black children mirror some population level patterns that have also been documented by economists. We do some calculations in the paper and estimate the cost per life saved of childhood Medicaid coverage is about 1.77 million. We also do some calculations regarding savings for hospitalizations that are avoided at age 25. But I want to quickly point you to a much larger growing body of evidence of improved later life outcomes for children gaining Medicaid. And two of these papers, Brown, Kowalski, and Lurie, and Goodman, Bacon, have really nice calculations in their paper that rely on their estimates showing increases in later life earnings and higher tax revenues for the government, as well as decreased use of public assistance programs in adulthood for children who gained Medicaid in childhood. And these authors estimate that the government either recoups 58 cents per dollar by age 28, which is in the Brown et al. Paper. Goodman Bacon looks at cohorts who gained coverage under the introduction of Medicaid in the 60s. So they're older, they've reached older ages in his data, and he finds that the Medicaid actually saves the government more than its initial costs. Sorry. Okay, and I'm just going to end by talking about Medicaid expansions for adults. So probably people are familiar with the Affordable Care Act and the option for states to expand Medicaid to low-income adults. This was a policy change that started in 2014. Currently, 39 states and DC have adopted expansions, with 11 states still deciding not to adopt expansions. This is an additional source of policy variation that we use to estimate the effects of Medicaid on health. So in this paper, which is joint with Sarah Miller and also with Norm Johnson at the Census Bureau, we look at the mortality effects of these ACA Medicaid expansions, and we use a new data source where we've linked survey data to administrative death data. And what this allows us to do is use information on individual characteristics that are not in administrative death data, such as family income, to identify the group that we think was most likely to gain Medicaid eligibility. So we're zooming in on this high impact group or targeted group under the policy change. We also focus on near elderly adults ages 55 to 64, because they have a higher mortality risk, and we believe this will increase our ability to detect effects of the policy. And then with this sample that we've constructed, we examine changes in mortality in expansion states as compared to non-expansion states. Here, this shows a similar event study design where we're showing changes in expansion states relative to non-expansion states compared to that year right before the policy went into effect. We were also able to link our data to administrative Medicaid enrollment data. And so we can document that there was a sizable increase in Medicaid enrollment after the expansions went into place, about a 13 percentage point increase in any Medicaid enrollment during the year for those in our sample. We also estimate a average of 43 additional Medicaid enrolled days per year on average. Using our data set, we next look at mortality effects And we find an immediate reduction in mortality in the first year, and some evidence that these effects might be growing over time. On average, during the post period, we find that the expansions reduced mortality for our sample by about 9.4%. For a subset of the data, we are actually able to get information on the causes of death. And there we show that the decline in mortality appears to be driven by decreases in disease-related causes or causes that are amenable to healthcare. We do some calculations in the paper and show that the effect sizes that we estimate indicate that there were about 19,200 fewer deaths in expansion states during our time period, which was 2014 to 2017. So over that 4-year period. We also estimate that if non-expansion states would have seen similar benefits from expanding Medicaid, this implies that there were about 15,600 excessive deaths in those states. And I will also mention that this mortality reduction that we find is consistent with some prior quasi-experimental work looking at mortality at the population level, and also is consistent with some really new experimental evidence of showing mortality effects of health insurance inclusive of Medicaid. So I've shown you a lot, and I just want to wrap up and say the empirical evidence that I've walked you through, I think, indicates meaningful health improvements from expanded Medicaid for several different population groups, so pregnant women, children, and adults. And this is an important benefit to document of the Medicaid program. I also want to say that none of these studies gives you a complete view of the health benefits or just total benefits of Medicaid coverage. Each of these studies only captures, one dimension or a few dimensions of health and well-being that were measured at a point in time. But we're going to need a lot more research in order to document what the even longer term effects were of some of these historic expansions, documenting whether there are positive or negative spillovers to other individuals in the healthcare system or individuals in the families of those who gain Medicaid coverage. I also think there's a lot of work to be done to better understand heterogeneity of program effects for different types of people and in different geographic areas. State Medicaid programs are very different. It's a joint federal state program, and states have a lot of flexibility in the design of their programs. So it'd be helpful to better understand how these average effects that I've shown you here today, how they look in different state environments. And then finally, I've talked about some very historic expansions in the program, but there have also been other expansions over time. And as I mentioned, continued growth in the program, including during the sort of national health emergency that we've had the last couple of years. And so I think better understanding Medicaid's role during that time period, as well as the benefits and costs of these additional expansions, is a great area for future research. And I'm going to end with a plug. Sarah Miller and I are currently looking at a population that is still not covered in the majority of Medicaid programs in the US, which is pregnant undocumented immigrants. And specifically, we're doing some work looking at California, which is one of the first states to expand their Medicaid program to cover this population group. And so we have a working paper that shows some evidence of health benefits, and we're currently working to look at the longer term effects. So stay tuned. That's everything I have. So thank you. Thank you so much.
Well, thank you so much for that, Laura. Super interesting. So we have some questions lined up here. I'm going to start with, I'm going to take the liberty of starting with one of my own, because it ties in with our last lecture was Leah Bustan from Princeton talking about immigration. And similarly to your work, nicely tying together longitudinal data over time to show how important it is to take this longer temporal view to fully realize and understand the effects of different policy changes. And one of the things that we talked about with Leah was the quality and availability of the data that we have to be able to estimate these really important policy effects. So I think in very characteristically American fashion, not only are our social policies fragmented and uneven and patchy across state and local jurisdictions, but also our data availability and quality is fragmented and patchy and of limited availability across jurisdictions. And so can you talk about just a little bit about data that are out there that are recorded that are either not available to the research community or not linked? Like what's your wish list for that? And then also data that we're not currently recording that we should be, kind of like what's an optimistic future for getting better data to be able to answer some of these questions?
That's a great question. And I think data limitations is one of the primary challenges in this literature looking at the effects of Medicaid on health. The type of data that are really hard to get your hands on, I think, are data that have clinical health outcomes and that you have for individuals with different payers, so who have different types of insurance coverage, as well as the uninsured. And it's really hard to get sort of that population level data on health outcomes. And so, there's the NHANES, which is a wonderful data set that does collect that information for a national sample, but the sample sizes are pretty small. So I think there are efforts underway to take more advantage of electronic health records across different healthcare systems and link them. And I think that's a really promising area for future research, especially if we can bring into those linkages electronic health records from community health centers and other providers that serve low-income uninsured populations. And then that would give us more visibility about health and healthcare use of individuals who are uninsured as compared to insured as well. So there are, though, I think some data that do exist that I'm really excited about that haven't fully been taken advantage yet of. And we use some of these data in the last paper that I showed you. The Census Bureau has done a lot of work on their data linkage infrastructure and has many different data sets in-house that I think external researchers aren't necessarily aware of their ability for research. And I think there's a lot of promise there. So you can put in a proposal with the Census Bureau through one of their federal statistical research data centers to use the data sources that they have, which include Medicaid enrollment information, include health information for everyone, mortality information for everyone with a social security number. So you at least have like that measure of health, and you can link those to the American Community Survey. Like that's the data set we were using in our last paper to tie together information on individual characteristics to health. Unfortunately, aside from mortality, I don't know of a lot of sources of data for other types of health outcomes, morbidity outcomes. And I think that's something that we really do less well on compared to other countries that have sort of this population registry of health information. And that's because a lot of other, high income countries have national health insurance, or they have other systems that record that information for everyone. So as you said, it's a reflection of sort of the patchwork of policies that we have here in the US.
Right. So it's not that the data don't exist, really. It's just that they're not stitched together. They're in, 10,000 different places.
Yeah, exactly.
All right. So we have some great questions here. So one of the first is, do Medicaid recipients have access to the same quality of healthcare as others, as non-Medicaid recipients? And is it possible to measure that or try to estimate that?
I mean, that is an excellent question. And I think there needs to be a lot more work in that area. And I think there are some research teams now trying to look at this and compare, for instance, outcomes for individuals who are on Medicaid versus those who receive subsidized insurance through the exchanges that were created under the Affordable Care Act, which are also low-income individuals. But I don't think we have great information on the quality differences between private insurance and public insurance. And I think that there's absolutely a need to better understand that. I think it's highly variable, I would expect, depending on the geographic area and the access to different healthcare providers that are available there. But yes, I think that's a great area to do future work. I don't know off the top of my head sort of the best way to tackle that question. I think it's a really difficult one, and any progress on that front would be a huge contribution.
It reminds me of some of Amanda Agan's work on looking at the differences in the quality of the legal representation you get when you're assigned a public defender versus having the court-appointed attorney versus having a privately. So it's kind of an interesting, like, can't use that design, but if we could come up with a design, we could estimate something like that.
Yeah, that would be great.
And so here's another question. Somebody's asking for clarification on the Nate Hendren work on the, really, I guess it's, I don't know if this is part of the marginal value of public funds project, but it's, recipients would have been willing to pay 14 times the cost. Just kind of how is that estimate constructed?
That's a great question. So it is the marginal value of public funds, and they're estimating individuals' willingness to pay for these programs. And they have a lengthy appendix that walks through all of how all of these calculations are made, but it's essentially assigning a monetary value to different benefits that researchers identify. So from our, I'm most familiar with the estimates that were based on our own work. So some of our specifications showed increases in earnings. So using the increased earnings estimate, using information on reduction in the costs of later hospitalizations. So it's essentially converting everything into some type of monetary form in order to calculate the value of those benefits.
Yeah, no, and I encourage people to go visit. There's a website where Nate and his collaborators, and I forget the name of the website, but if you do remember, I don't know if you know it off the top of your head, Laura. It's called something. It's not marginal value of public funds because that wasn't catchy enough. It's something, but they have a library of policies where they're estimating this kind of the social return to these different policies, and they take published estimates from the literature and then they run them through a series of calculations to try to find a comparable benchmark across all of these different policies of, like, here's the social return on this policy versus this policy. And so it's a super interesting project.
It's a great project, yeah.
Yeah. So could you talk a little bit about the paper that was the findings that got publicized last week in the Times about the racial disparities? It's really interesting finding that these infant mortality and maternal mortality rates are, even once you control for income, there's a very large racial disparity within the United States in those adverse outcomes. And I'm just curious if you could talk a little bit about what you all think is going on there and what kinds of policies or strategies we would want to turn to address those.
Yeah, that's a great question. So the study that you mentioned used data from the state of California, where we administrative data on infant and maternal health that we linked to individual income or parent income information from the IRS. It's a really unique study in that we're able to look at income gradients using individual health. And what that paper shows is there are income gradients in measures of infant and maternal mortality, which, as you would expect, the highest income families do better on those outcomes. But what I think really stands out from the paper is the differences we see by race. So we look at differences by mother's race, and it totally swamps the differences that we see by income. So even the highest income Black families are doing worse than the lowest income white families in the state in terms of many measures of maternal and infant health. And I think the findings are really important because it shows that income is not explaining these racial differences. It's also a bit discouraging because the state actually has a lot of efforts, more efforts compared to other states trying to address disparities in infant and maternal health, and specifically to improve infant outcomes for Black families. So it has different initiatives that have been in place for some time. And the state also has a more generous social safety net than a lot of other states. So to see these differences in the state of California is, I think is discouraging. And, we talk about in the paper, we don't know for sure what was driving this. And I think in later studies that we're going to hope to try to look at some of the mechanisms if possible. But I think it really points to a need to address people's concerns outside of the healthcare system. It could also be the case that these families are facing discrimination within the healthcare system that matters for their health outcomes. But we know that there are also other elements of discrimination that Black families, for instance, face throughout their lives. I will also say that until recently, and you saw this in the talk today, the public health insurance programs in the US really only have paid attention to women once they become pregnant and provide access to prenatal care. And that may just be a little bit too little, too late. We know that other exposures during a woman's life or a pregnant person's life also matter for their health and the outcomes of their pregnancy. And so I think thinking about it from more of a life course perspective, and thinking about supports that we can provide earlier on in these women's lives could be a really important area for policy improvement, I think.
All right, it's time for one more question. You in particular, and you and your collaborators have been working on these Medicaid expansion papers for a while now. Have you noticed, and I have not kept track of the states that are expanding, but have you gotten any feedback from state legislatures, governors' offices that suggest that maybe they're reading these papers and there's actually some impact happening here, that you're actually contributing to supporting the further expansion of Medicaid across the states?
I mean, that would be some wonderful feedback to receive. I will say we are sometimes contacted by advocacy groups in states that have not expanded, that are, trying to make a case using some of our estimates. And so, it's always nice to hear when people are paying attention to your research and that perhaps you are, providing some evidence that other states could use in their decision-making process. But I think, that's sort of the extent of the feedback that I've received. And it's always really nice to hear. So.
Well, that's what I choose to believe. That's the story I choose to tell ourselves. Laura, it was so great to have you here today. It's really important, groundbreaking work that you and your collaborators are doing on Medicaid expansion, and we all look forward to seeing more of it in the years to come. Thank you so much for coming.
Thank you so much for having me.
All right, thanks everybody. Have a good rest of your weekend.